Good evening, and good evening, Cheryl, and welcome, and thank you very, very much for joining us. This is the fourth of our series of lottery-funded webinars, and we are extremely grateful to have you here chatting to us as our expert on andrology. You can see us on Facebook, on our webpage, and if you have any questions, you're welcome to start posting them as soon as you wish. Can I introduce you formally? Thank you for joining us. Esteemed member of our medical panel, Andrology Solutions, andrologist, fellow scientist. Would you like to start off by telling us a little bit about what an andrologist does, what you do? Most of the people I encounter when I mention andrology, they look politely and they go, sorry, or what? Or what's that? So I think there's probably a bit of gap filling that's necessary if you're happy to do that.
Yes, no, absolutely. And I think we're all very familiar what gynecology is. So andrology is the male equivalent. So it really looks at the health and the unhealthy aspects of the male reproductive system. So that's basically what andrology is.
Andrology is brilliant. That's great. And of course, as part of your role as andrologist and running Andrology Solutions, could you give us some idea of what happens at Andrology Solutions if somebody is referred to an andrologist? What are they likely to expect?
Well, I think when we talk about andrologists, certainly in this country, there are two types of andrologists. There's the scientific aspect, which I am, and we primarily work in the laboratory. So we're involved in diagnostic testing, investigation, and we're also interested in the scientific aspects of the causes, the root causes of male infertility and what the diagnostic tests can tell us. The other andrologist is usually a consultant urologist with a special interest in male infertility, and usually these andrologists are practicing male infertility day in and day out from a medical point of view. So they are seeing patients, investigating them thoroughly, and then using the results of the investigations and diagnostic tests to come up with a management plan for male infertility to try and improve that person's reproductive health. But it's also not just about infertility, and I think this is very important. When you're talking about gynecology, there are gynecologists that specialize in infertility, but there are also gynecologists that specialize in general health and well-being of the reproductive tract at any age of the woman. And likewise, an andrologist would specialize, and particularly the doctors, the consultant andrologists, are specialists in the male reproductive tract. So they're looking at pathologies, they're looking at ways of dealing with that pathology and managing it appropriately. So we have to really look at andrologists as being the antithesis of gynecologists for the men in general.
So when a couple are thinking about their fertility, they might have been trying to conceive for a period of time. They may have got as far as deciding to go to their GP to have a conversation about the fact that things are taking longer than they might like, or they may not even necessarily have got to that point, but they may want advice and information from their GP. Is it a reasonable suggestion that both members of the couple should be investigated at that point, or is there a sequence of events that should take place?
Fertility involves a male and a female, as we all know. Pregnancy involves the woman primarily, but it also involves the creation of a healthy embryo. I think it is essential for the couple to be seen and investigated together, and not for the focus to be on the woman. It has to be equal in order to understand what the potential causes might be.
So if a GP was wanting to make a referral to an andrologist, is that, or should it be as straightforward as it might be him wanting, or him or her wanted to make a referral to a gynecologist? Is there almost a his and her referral that can be made?
I think so, yes, because obviously the GP is the general practitioner.
And the gatekeeper sometimes as well.
Exactly, the gatekeeper. So the GP has a fundamental role in determining the pathway for that couple. Once you have overcome the general investigations, the general discussion, the couple should then be referred to their respective specialists, the woman to the gynecologist and the man to the andrologist. After all, if you have a heart condition, the GP would invariably be doing some initial investigations and then referring on to a heart or cardiac specialist.
So talking about the initial investigations, because a couple are going to have to start somewhere, what would be a reasonable minimum for them to expect from their general practitioner, from their GP, and what sorts of things should they be asking from their GP?
So depending on the situation, if the couple are anxious about their fertility and they want to have a few initial investigations, obviously for the woman it would be appropriate for her to have an initial hormone profile carried out at the early part of her cycle, just to make sure that her hormones are functioning normally. And for the man, it would be appropriate to offer a semen analysis as a very early initial investigation, just if they were a little concerned and they were just starting out, things were not happening. However, if they had been trying for 12 months and they clearly aren't conceiving, then further investigations would need to take place. And for the man, it is very interesting that recently WHO have published draft guidelines for investigation of the male partner. And as a minimum, they recommend a semen analysis together with a full medical history and a physical exam. And that is the bare minimum for an initial investigation of a man presenting with infertility. In other words, trying to conceive with regular intercourse for 12 months without a conception.
Right. And would it be the GP that would be the right person to be doing this physical examination? And obviously the laboratory are going to be involved in the semen analysis. But is that the right place, or would they need to be referred immediately to somebody more specialist?
I think WHO doesn't delineate who does it. I think that as long as the GP is instigating these initial tests, what WHO then goes on to say is that if there are any abnormalities, any at all in the medical history, or with the physical exam, or with the semen analysis, and I emphasize here, not with all of them, with any abnormality, the patient must be referred to a specialist who specializes in male reproductive health.
Right. And maybe a slightly risky question to ask, are these services available on the NHS?
Are you talking about the diagnostic?
Yes,
the testing?
The initial diagnostic testing.
There are many laboratories out there that are properly accredited to do full detailed semen analysis. It is essential, however, that the semen analysis is performed in a properly accredited laboratory. And by accredited, I mean by the UK schemes for accreditation, such as UCAS, or at least CPA, because not all of the laboratories are UCAS accredited at the moment, but as a very bare minimum. The problem is that if they don't have the accreditation, there's no way of telling whether the analysis that they do is reliable.
Right. And this isn't something that necessarily the average person would be aware of, or would necessarily even realise when being given a referral. So in terms of the sorts of questions that they should be asking when given a referral,
yes,
what is a sensible question for such a person in that situation to be asking? They'll be given they'll be given a form, as it were, or something like that.
I mean, it's difficult because if you go for a blood test, you would hope that that blood test would be reliable for you.
That's right.
That it wouldn't be an unreliable result. And there are laboratories that don't have full accreditation for one thing or another. The problem with semen analysis is that the results vary so much from laboratory to laboratory when there is no accreditation, that it becomes difficult to determine how meaningful it is, and especially when so much is at stake. That I think it's a fair question to ask your GP, to ask if the laboratory that the analysis is being carried out in is properly accredited.
I mean, especially for a lot of our Chana service users, being sent for semen analysis is no small undertaking, because there are religious considerations, there are halachic considerations, and therefore they want to be certain, if they are going to be doing the test, that they're going to be doing it in the best possible way and getting the most informative data from it. So I think that's a useful question to be asking.
I think certainly in our professional field, we have all come up against this as a major problem. We, as andrologists in our professional capacity, are trying very hard to establish a national standard. Now, there are standards, but we need to make sure that we're all following the same standards so that we can compare. So if a patient has a test done in Gloucester and moves to London, that they need to see whether or not things are similar, that they can compare results. And that also that they can feel confident that if they are diagnosed with an abnormality, that they can have confidence that this is a reliable result.
That's very helpful. So if we look at the bigger picture of male infertility, the question that we set out to ask is, how common is male infertility?
This is a very difficult question to answer.
Sorry.
And many studies have been done on this throughout the world. The main problem is that the results themselves might be unreliable because of underreporting. In many countries, it's not reported. The men don't want to address it. They don't want to go to their doctors. So it may be a huge underestimate. What we think is that globally, infertility may occur in approximately 2.5% to 12% of the population.
Okay, that's quite a range, isn't it?
That's quite a range. And the reason is that if you look at Western countries or Northern African countries, you are seeing the highest incidence of infertility. And we see about a 10 to 12% incidence of infertility in Northern Europe and Central Europe. And if we look at the incidence of male infertility in general, there are about 15% of couples who have issues with fertility.
And that's male infertility or infertility in general? Right,
general infertility issues. And of those couples that have infertility, the distribution is equal. Approximately 50% of infertility is attributed to the man and 50% to the women.
Right.
Now, if you look at male factor issues being the sole problem, the estimate is approximately 20 to 30% of couples with infertility. The sole factor is coming from the man.
Right. And to put that into a context for our viewers, if you were making the same assessment of solely female infertility in the couple, how do the numbers compare? So if you were suggesting, as you have, that 30% of couples who are experiencing infertility, it is solely responsible, or maybe I should rephrase that, solely down to a male factor issue, how many couples would you suggest the same would be for a female issue?
It's probably about 40%, something like that. But then we do know that other studies have shown that about 30% of infertility remains unexplained.
Unexplained, yeah.
And we do know that about 25% there seems to be a problem with both.
Right.
Now, I know those numbers don't add up to 100% because
No.
different studies have shown different things.
Yes.
In some studies, they show that there may be a male factor contributing to about 70% of couple issues, of infertility.
Issues, right.
So it's very, very difficult.
It is difficult, but it's
on
certainly
balance,
not an insignificant number. I think that's
it
the
is
important
not.
take home on this, is that certainly from what we have seen over an extended period of time, is there are often assumptions made that, as you said, pregnancy is about the female, but fertility is about both members of the couple, and we often see the assumption being made that it isn't.
Exactly.
Without fully investigating, and I think that's certainly something that's very, very important. Now, in terms of understanding why there is an infertility issue, what sort of, and I know it's a big question, what sort of factors might contribute to male factor infertility?
So for male factor infertility, we would really be looking at medical issues. We would also be looking at lifestyle issues. And we may also consider the psychosexual issues as well, which would be a major. Those are the major contributing factors.
Right. So in terms of the medical history of the individual,
yes,
are there any situations that someone may have experienced a particular medical scenario that should make them more aware than the average of their fertility?
Yes. Now, we can look at direct situations. So, for example, a man who is born with undescended testicles, he may have had them repaired at some point while he was younger, has a high chance of having issues in adulthood for fertility. Likewise, if we look at men who have had a history of a systemic illness, kidney problems, for example, diabetes is clearly associated with male infertility, and that is accepted as an awful lot of evidence for that.
Is that diabetes that is well managed or unmanaged?
Obviously, if it's unmanaged, it's going to be more of a problem.
Yes.
Even if it is managed, there are biochemical molecular events that occur that will impair blood flow into the testes. It will impair oxygen and nutrients getting into the testes. It will cause superficial nerve damage that will also affect the functioning of the testes. So it is very important to keep an eye on sperm quality if you know that you have an underlying systemic illness. And again, that's very important, because if somebody is not aware that they have a systemic illness and they have a semen analysis which comes back with poor parameters, they absolutely have to get themselves properly investigated, because it could be a secondary effect of an underlying pathology which needs proper investigation.
So they might find out maybe a little bit more than they bargained for.
Exactly.
But
Exactly.
in the grand scheme of things, that's probably doing them quite a big favour. So that's really the medical scenario. Now, of course, we don't want to start worrying anyone unnecessarily or alarming people. In your experience, do you find that if it's the endocrinologist that's looking after someone for their diabetes, or the gastroenterologist that's looking after someone for Crohn's disease, for example, are these clinicians sufficiently well versed in the area of fertility to be able to give the right support to their patients if their patients are concerned about their fertility, or should they be involving a third party?
I think they do involve third parties. I think certainly with something like Crohn's, like diabetes, I think it's well established the effects on fertility. So I would be surprised if they didn't if they weren't making their patients aware of the potential side effects of the condition. But it's always a good idea for a patient who's perhaps seen his endocrinologist since he reached puberty. Maybe the doctor is not aware that he's currently preparing to have children, to discuss it with the doctor, and if there are any concerns, to have a semen analysis. But there are plenty of other medical issues that have a direct impact on male fertility, and these are things also that are very important to consider if a man is having problems conceiving.
And likewise, certain prescription medications that they may be taking for other conditions,
yes,
could have a significant impact in certain scenarios.
Well, yes, and drugs certainly. I mean, there is some evidence that might associate medication or itself hypercholesterolemia. So whether the hypercholesterol levels itself is causing problems, or whether the statins themselves are causing problems for male infertility. There's some discussion about that as well. Antihypertensives might be associated. We certainly know there's a lot of evidence about SSRI inhibitors for depression have a significant impact, not just on semen quality, but also on the intrinsic genetic integrity of the sperm as well. So that's rather more worrying and of concern. So that's really very important that you discuss that with the doctor, and whether or not there might be some other medication that you might be able to take that's less harmful to
if we go back to the biology of sperm and sperm production in the context of these prescription medications, which I think it's very important to point out that if someone has been prescribed a medication for a particular medical scenario, that they can't take the law into their own hands and change their medication without careful discussion with their clinician and their pharmacist.
Absolutely, they have to speak to their doctor about it, and if it's not possible for them to change their medication, and in many cases it isn't, then we will try and things can we'll just have to manage as best we can.
So there are ways. So if we could discuss for a little while the biology of sperm and the production of sperm, and maybe really in the context of understanding how certain lifestyle choices could impact on the health or well-being of someone's sperm, because I think the medical scenarios are what they are, and the clinicians who are looking after the individuals will help someone through that, as you say, changing medication or not. But if we're talking about an otherwise healthy male, can we look at the biology of their sperm production for a moment, and if you could give us some idea of how that actually happens?
Yes. So when a boy is born, he is born with very primitive, what we call germ cells, that are the progenitors of sperm. And these cells lie dormant until puberty, when they begin to develop and grow. And these cells are capable of multiplying throughout a man's life to generate more early immature sperm cells, and they will continue to do this throughout a man's lifetime as long as he is normally fertile. Some of those cells, once they've divided, will start to specialize, to develop into what we now know as the mature sperm. And that particular part of the development process takes approximately three months, about 11 weeks actually, from the time that process is initiated. Now, men usually start making about 1,000 sperm a minute.
A minute?
They are making a lot of sperm. Sperm are made in seminiferous tubules. There's about 6 kilometers of seminiferous tubules packed into those testes. And a lot of sperm are made every minute of the day.
So never let it be said that a male is idle.
This is true. There are many millions. Now, of course, when they are dormant, they are basically asleep. They're metabolically inactive. They're quite tough little creatures, but once they start developing, they become very vulnerable. One of the most important parts about sperm development is the division and compaction of the genetic material that must change from being enclosed in a little membranous sac inside the germ cell to a very small, tightly packed piece of DNA that's packed very tightly inside a sperm head, which is a lot smaller than its original germ cell.
Right, so you're squeezing it into a tiny
You're squeezing
space.
it in. And during that process, that DNA is very vulnerable to attack.
Right.
So it's very important that the sperm are not exposed to any toxins during their development.
So what sorts of things could attack, if you like, this very vulnerable DNA?
Okay, so there could be all sorts of things that can damage the DNA. One of the most important things is something called free radicals. And free radicals are generated as a result of what we call oxidative stress. And oxidative stress is the process that is the underlying cause of most of the major known causes of male infertility. So we know it's very important. So all of the major known causes, for example, varicocele, which is the leading known cause of male infertility. Varicocele is a clump of varicose veins in the testes. You get an engorgement of blood into the testes, which heats up the testes because the blood comes from the body, which is at 37 degrees. The testes are outside the body. They need to ideally be 33 degrees, about 4 degrees.
Which is why they're outside the body.
Which is exactly why they're outside the body. When the blood is engorged in the testes, it heats them up and it generates oxidative stress. So it basically oxidizes anything it comes into contact with.
So it's a type of heat damage.
It is heat damage. So varicocele elevates testicular temperature. It generates oxidative stress. That in turn oxidizes, damages the surface of the sperm, causing problems for the sperm to function normally, to be able to fertilize the egg, so it interferes with fertilization. It can also get into the sperm and damage the inside of the sperm, to damage the energy powerhouse of the sperm and slow the sperm down, kill the sperm. It can also get into the genetic material, oxidize the DNA and break it, causing DNA damage.
So in the semen analysis that we were talking about earlier in our conversation, assuming that the sample is sent to an accredited laboratory, these changes, how obvious would they be to the operator that is performing the analysis?
Not at all.
I was worried you might say that. So for somebody who has experienced this kind of damage, be it through a varicocele or varicocele, is there any way that they would be aware of the fact that they might be in that situation and need to have that investigation performed? Other than obviously the failure to conceive, but if we're looking further into the investigation process.
You see, it's interesting because 30% of infertility is unexplained. My personal feeling is that the reason it's not unexplained. People haven't bothered to try to explain it. And it's these underlying molecular mechanisms that might be contributing to this so-called unexplained infertility. Because the interesting thing is that although oxidative damage can damage the powerhouse of the cell and reduce motility, reduce vitality, impair morphology, so you might find a reduction in motility and vitality, it doesn't always do that. It might go straight into the DNA and damage that instead. So you may see motility is fine, sperm is swimming great, the vitality is good, morphology is, and you might not see any impact at all on the sperm. Certainly, if you do see problems with motility and vitality, you might suspect oxidative stress. Now, there might be many reasons other than varicocele where you can generate oxidative stress. So infections, for example, will generate oxidative stress. Inflammation, such as inflammation of the prostate, which is very common in men. A lot of men get very worried about that. Any mention of the prostate, it's cancer. This is not cancer. We're not talking about cancer. We're talking about inflammation of the prostate, where about 50% of men will experience this at some time in their lifetime.
Would they know that they were experiencing this?
Again, some prostatitis, they may feel uncomfortable. If it's early inflammation, they occasionally have some urological symptoms, occasionally getting up at night to urinate when they haven't drunk that much water, a little bit of interruptions in the urinary stream, perhaps a little bit of urgency to go, sometimes perhaps a little bit of pain at urination or whatever, occasional, very occasional, and they may not even notice it. But my recommendation is that if you have any symptoms at all, go to your GP and check it out. But these are the sorts of things that will instigate oxidative stress, which in turn can have functional effects on the sperm, damaging the fertilization process, damaging the DNA, and indirectly having an effect then on your fertility.
So this brings me to something that I would hope would be obvious, but I fear isn't necessarily, is the need for very accurate and careful examination, and then hopefully leading to a clearer understanding or a clearer diagnosis of what the scenario may or may not be.
I think it's very important for the man to have a physical exam, or at the very least an ultrasound scan, where you can investigate the testes and see whether or not there's a pathology there. A testicular ultrasound scan will reveal a varicocele. Now, not all varicoceles cause fertility problems. There are plenty of men, about 15% of men with varicoceles walking around with perfectly normal fertility. The varicocele needs to be what we call a clinical varicocele, so that it's palpable, so that you can feel it. But you could certainly detect it on an ultrasound scan. Again, it may not affect fertility. We do know that about 40 to 70% of men who are subfertile may have varicoceles. And in that case, it's highly likely that if they are subfertile, that the varicocele is having an effect. And again, we need to know what the situation is. If a man is having problems with his fertility, he needs to have a physical exam or a scan. Just like a woman who's having problems with her fertility needs to have a scan. Does she have a fibroid impinging on the uterus? Because that's going to affect her fertility. You wouldn't know that just by doing a hormone profile. So, you know, this is essential.
You need to have a look, see what's going on inside.
Exactly. So we need to know from them what's going on.
So looking on the optimistic side, that a careful examination has been performed and a diagnosis has been made, are any of the scenarios that we've discussed, for example, the oxidative stress or the DNA fragmentation, are there any ways to reverse this situation? Or if someone's been given a diagnosis, that's the diagnosis and there's no turning back?
I mean, obviously, you know, if you have an infection, for example, that can usually be managed appropriately with antibiotics. What's a little bit worrying is that if a patient comes into the doctor with symptoms and the doctor diagnoses it as a non-specific urethritis, for example, and prescribes a broad spectrum antibiotic, this is a little bit worrisome, because after discussion with my colleagues who specialize in infections and who are microbiologists, it could potentially be quite dangerous doing that, because if you haven't pinpointed the exact organisms, you know, the problem with bacteria is that there are a lot of lovely bacteria
And
around,
we need some of them.
and we need a lot of them, and our health depends on a very delicate balance of the microbiome in both the female and the male genitourinary tract. And it's when you get an imbalance and an overgrowth of some of these organisms that it may become problematic. What you don't want to do is give a broad spectrum antibiotic that doesn't target the one that's currently overgrowing. Mm-hmm. And if that's the case, then the one that's overgrowing is going to be in heaven's delight. In fact, it's going to overgrow even more because it has less to compete with. So it's very important that you get a proper analysis and identify clearly what the issue is before you start to treat. And I would say that's the same thing with something like antioxidants, for example, which I'm a fan of. I think antioxidants, when I'm talking about antioxidants now, I'm talking about fertility supplements. Yeah. Fertility supplements are antioxidants. They work by reducing oxidative stress. That's how they work. Now, most people take supplements, they have no idea what they work, how they work, what they do.
No, they just read the packet.
So how they work is that they overcome oxidative stress. The problem with antioxidants is that if you don't have oxidative stress and you take antioxidants, you wipe out oxidants altogether.
And now, that means that presumably some of the oxidants you actually need to have them in the system.
Absolutely. Nothing is black and white. So we need, just like we need certain bacteria for our general health, we need very low levels of oxidants to promote fertilization and healthy embryo development. It's when we get overproduction of oxidants that we get the trouble with the sperm. So my recommendation would be that you test for oxidative stress. If you have oxidative stress, the first thing you need to do is get to the root cause. What's causing it? Is it a varicocele? Is it an infection? If it is so, treat the infection with antibiotics. If it's a varicocele, consider discussing varicocele repair with your doctor. But if it's none of the above, it may be that your natural antioxidants are not working properly, and that's why you've got this overproduction of oxidants, in which case you must take supplements.
So it's really important for somebody, before they even consider taking any form of supplements, that they investigate quite carefully what the situation is, rather than just popping supplements here and there.
Exactly. We need to have a properly thought out management plan.
So going back to the fact that we understand that sperm takes 11 to 12 weeks to be regenerated or to generate new sperm.
Yes.
Is there any cause for optimism in terms of somebody who does have any one of the scenarios that we've discussed, that they could, if you like, reboot the system and be producing healthy sperm where previously they might not have been?
Studies are currently showing that where varicocele might be a problem, varicocele repair can improve semen quality in about 60 to 80% of cases.
That's phenomenal.
And it can improve pregnancy rates in about 20 to 40% of cases.
That's definitely cause for hope, isn't it?
Cause for hope. The caveat I would say is that there's now more evidence coming to light, and this was reported, I understand, in the recent ASRM meeting in America, is that people who have a genetic predisposition to what we call a testicular dysgenesis syndrome might be also more at risk of developing varicocele. Now, in those cases, irrespective of the varicocele, these patients have problems with testicular function. Sperm quality is declining in general because they have this syndrome. So when they repair, the varicocele is probably exacerbating things. So when they have the varicocele repair, for a few months, 6 months to a year, everything looks fine and hunky-dory, but then semen quality starts to go back again. Now, it may be because the varicocele is coming back, you should always check that, but it's more likely because this is the group of patients that have this syndrome and their testicular function is going down anyhow. And in those cases, these patients need to store their sperm. I would probably recommend that if people do have varicoceles, they have varicocele repair, quality improves, they need to consider storing their sperm just in case it turns out that they also have this testicular dysgenesis.
How easy or difficult could that be to achieve, to store the sperm?
Well, fertility clinics are reluctant to store sperm for people who are not their patients.
Yes.
Likewise, on the NHS, I think it would depend on what doctor you're seeing and who's referring you. There are particular NHS units that do store sperm, such as Hammersmith, such as UCH. They're very good at storing sperm. And of course, there are private clinics that will also store sperm as well. But obviously, there's a cost involved.
Yes.
But nevertheless, it's something to bear in mind. And of course, with infections, we all know that antibiotic treatment often results in a significant improvement in sperm quality, and it has also been shown to increase natural pregnancy rates as well as IVF pregnancy rates.
So again, getting the infection under control is quite important, especially
Yes.
since they may not necessarily be directly aware of the fact that there is infection in the first place.
Yes.
Could we talk for a moment about lifestyle and sperm production, because there are increasing numbers of reports in the press how generally sperm numbers and sperm quality is on the decline. Is that a general trend? Is that a specific group of people that we're talking about?
It's also a little bit difficult to get to the bottom of it because people have been reporting on male infertility for decades, for many, many years, but the methods of assessing male infertility have improved and have become a lot more strict as time has gone on. So we don't know the extent of the changes, but nevertheless, putting that aside, I think all of the studies that are coming out now, especially the one that came out from Israel a couple of years ago, clearly shows a decline in male infertility over the years, a significant decline. And interestingly, this tends to be more focused in the Western world, in the Northern Hemisphere, but also in Australia. So where you have a world that is more exposed to lifestyle changes in a way that is not as drastic as other countries, we see a significant decline in male infertility.
So if we were to be more specific about lifestyle choices and general health, but more specifically sperm health, are there any suggestions that you could make, not just necessarily to couples who are planning a pregnancy, but just in general?
Yes. Well, we know that, as you said, that 11 to 12 weeks when the sperm is developing is where they're at the most vulnerable, where they are exposed to products coming from the blood, the nutrients that will diffuse into the testes that will affect them. So one of the most toxic things that you can do is to smoke cigarettes. Cigarettes contain a huge amount of toxins in them, chemical toxins, that have been shown not just to alter semen parameters, but insidiously they can affect genetic programming in the sperm. such that you can pass on single gene mutations, or what we call impairment in epigenetic profiling, which is latter modification of the genes that can then be passed on to generations. And unfortunately, what we find is that in people who smoke, there's lower birth weight. We know there are more problems with these babies born prematurely. And more insidiously, these children are much more at risk of developing childhood cancers and childhood diseases. So I always say to my patients, when you see a heavily pregnant woman walking along the street and she's smoking a cigarette, how do you feel? And all of them, without exception, say, that's absolutely terrible. But actually, it's really not as bad as the damage that is done to eggs or sperm while they are developing as a single egg and sperm, because the damage you do to that single egg and sperm is then passed on to every single cell in that fetus. Whereas with a developing baby that's 8 months old, only some of those toxins will ever make it to the organs, because there are a lot of defense mechanisms that can deal with it.
So the cigarettes really are a very serious problem. And we know that there are, for those people who do smoke, there are lots of programs available to help them to stop smoking. So it's worth mentioning that. So other than cigarettes, are there any other lifestyle
major issues? Another major issue is obesity. Anyone with a BMI over 25 is much more likely to experience issues. Now, obesity issues are related to imbalances in hormone production. Testosterone is converted to estrogen and fat cells, so you get a decrease in blood testosterone levels. You get a reduction in testicular size. You are also going to experience a increase in scrotal temperature due to the increase in local fat tissue and the heat generated by friction in that local area, which in turn is going to cause oxidative stress, DNA damage. Obesity is associated with a reduction in all of the semen parameters. It's also associated with an increase in DNA damage in the sperm, and it's also associated with a significant increase in men with severely low sperm counts or no sperm at all. So that is a major factor. And also the association with diabetes, of course, and we mentioned that before. And of course, the types of foods that these people tend to be eating are wholly inappropriate for sperm development. A lot of fried foods is oxidized food, and it's actually, some of it is even carcinogenic, but it does cause huge problems for oxidative stress. Another factor that we know, several studies have been done now on cola drinks and soft drinks, which have a significant impact on semen quality and sperm DNA. So that's another thing that is a real issue. Processed foods with anything, people need to eat food. You know, people don't eat food. They eat things that are chemicals with flavorings, additives, artificial colors and sweeteners. There's no food in there. They need to eat proper food that as a human being we would be eating. In other words, we need to stick ideally to the Mediterranean diet. And that means lots of fresh fruit and vegetables, lots of oily fish, and lots of olive oil. Tomatoes are key.
Okay, that's very helpful. And going back to what you were saying about supplements, might there be any supplements that could be available in a diet form as well as possibly in extras?
Well, this is the thing. Ideally, we want to be getting all our vitamins and minerals because they are antioxidants. So we need to be getting those from our diet. So obviously, fresh fruit and vegetables, very rich in all these antioxidants. And we need oils, the essential oils from the fish.
So the 5 a day actually have many more benefits than just those that we see advertised. You know, we always associate it with cancer and prevention and well-being, but actually it's well-being on a larger scale.
Absolutely. Yes, your sperm health reflects your general health.
Now, in terms of occupational risks, we've talked about lifestyle risks, cigarette smoking, BMI, that's the body mass index, the weight. You haven't mentioned alcohol intake. Is there anything to say about alcohol intake?
Well, again, a lot of these, alcohol is a natural product. We make alcohol in our bodies, but we only make it at low levels, and our bodies are very good at dealing with it. What our bodies are not good at dealing with is excessive levels. So we need to be very careful about how we drink alcohol. So an occasional glass of red wine, which incidentally is rich in antioxidants, is probably unlikely to harm us. I mean, I think that levels that are quoted in the guidelines tend to be a little bit dubious, because it's, if you drink 25 units, it's okay, but if you drink 26, it isn't. Every human being is different and can tolerate different levels. As long as we're not doing anything in extremes, that should be fine. So very moderate your alcohol intake would be my recommendation. No recreational drugs. So yeah, definitely that.
And in terms of occupational risks?
Occupational risks, obviously heat damage is the major thing, and also exposure to toxins, chemicals, pesticides. So people who are gardeners, for example, who are working with lots of herbicides, pesticides, farmers, for example, have problems. Chefs, bakers have issues. People who work in foundries, jewellery making, where they're working with lots of lead and toxic chemicals. People need to be very much aware of that. Painters, decorators, work with organic paints in water-based. So, and wear your health and safety equipment. It's there to be worn. Don't breathe in the fumes. Wash your hands after you're handling things that are toxic, because they can get into us through the skin. So you do need to be very careful. Again, athletes have problems because extreme exercise.
I was going to ask you about exercise.
Yes, causes a huge amount of problems. Problems for
cycling in particular, or just
cycling in particular. That's very interesting, because you have the friction on the testes, and also a lot of professional athletes, but even cyclists who cycle to work, it's been shown that that is a problem for them. For just, you know, ordinary, you know, weekend bicyclists, taxi drivers, lorry drivers, the heat on the testes. Is
that because of the activity or because of the clothing that they're wearing to do the activity?
We think it's a bit of both. So the thing is, don't bicycle if you're trying to achieve a pregnancy, and don't drive long distances without getting up and down. But in terms of extreme exercise, no matter what exercise you're doing, if it's extreme, again, you have that problem of damaging sperm quality as well. Moderate exercise, except for cycling, because there's the physical thing. Moderate exercise, a bit of weightlifting, aerobic exercise, yoga, Pilates, all this sort of thing. Walking, great. You know, you can run as long as you don't have thick thighs that are rubbing against your testes. You've got to think about the heat impact. You've also got to think, as an athlete or doing extreme exercise, about testosterone, because it's only made in the testes. And if you're requesting testosterone to build up bone and muscle strength, you're depleting it from the testes. So the bigger the muscles, the smaller the testes, the poorer the fertility.
So bodybuilding and that sort of thing is a real worry.
Any anabolic steroids or supplements that people are taking may completely wipe out your sperm altogether.
So going back to the 11 to 12 week turnaround time, for couples who are planning a pregnancy and may be involved in any of the activities that we've discussed, can they take any optimism from the fact that changing any of those particular activities, be it going on a calorie reduced diet or be it changing their activities in terms of their exercise regimes, are they likely to be able to improve things for themselves?
I think all of us in the field can see that if people do look after themselves, that they are more likely to have healthier reproductive systems, and they are more likely to conceive. So it's being sensible, don't smoke, don't cycle, eat a healthy diet, get a lot of sleep, try to relax, and make love, lots and lots.
Okay, so there are lots of optimistic tones to what you're saying, and I think maybe an important message, because we do see here at Chana couples who struggle on lots of different levels, and the emotional level is a very important one that we think about here as well. And you know, we have a team of support workers for both males and females and for the couples, and that's a very important part of the services that we're offering. Am I guessing that in some cases couples can really take a lot of charge of the situation for themselves before having to necessarily go for medicalized help?
I think it's always a good idea to do that. I think what does concern me sometimes is that people get overly worried, overly anxious. They start taking their temperature, they start doing their ovulation prediction kits and everything. It all becomes very mechanical. Actually, when you're we find that when people are most likely to conceive is when they're relaxed and they're on holiday. And they're not thinking about anything else. Is there a prescription
for holiday?
They're just relaxed. You know, it doesn't matter. You know, you can just turn your phone off and just lock yourself in for a weekend and just sit in the garden and have a nice romantic dinner, and you're much more likely to conceive. If you start worrying and getting concerned about everything, causing a lot of adrenaline to build up, a lot of cortisol. We know that anxiety can suppress reproduction. I mean, we know that from the animal world. If you just look at animals in stress, they start reproducing. So relaxation is very important. There's also the psychological aspect as well, seeing your family and friends, getting pregnant, having children. It's so demoralizing. And every time, you know, every month the woman has her period, and it's soul destroying, absolutely soul destroying. There's pressure, there's huge amounts of pressure. For the man, the pressure is to perform, and his libido may decline because of the pressure and the anxiety that's happening for the woman, and it's just not going to happen. It can't happen because the environment isn't right. So we do know there is evidence out there that shows that there is a considerable impact of the sort of psychological aspects and the anxiety aspects.
So taking care of the emotional well-being is really quite important. Once you've taken care of all of the physical aspects that we've discussed. Cheryl, thank you very, very much. You've answered a lot of questions. You've given us a lot of information. We're extremely grateful. As I have mentioned, our telephone helpline is open for some hours of every day. We will be able to take calls over the phone or by email. You can contact us through our website. If you have any further questions, thank you again for joining us, and thank you.